CALOR trial.
Thank you. It's a pleasure to introduce you to the CALOR trial. I'm presenting this on behalf of investigators of the NSIBP, of the Breast International Group, and of IBCSG, and I want to say that I'm presenting also on behalf of my co-chair who's sitting in the first row here, Dr. Wapner from Stanford. CALOR stands for chemotherapy as adjuvant therapy for locally recurrent breast cancer. The trial addresses the treatment of women whose breast cancer recurs only in the breast or in surrounding areas. This is to say they had no distant metastases at recurrence. The standard of care for these patients is surgery and radiation therapy, and it was unknown whether they can profit from chemotherapy. The question is obvious, and previous attempts to answer the question have not been successful. So CALOR is a global trial, and this is the first one to provide a clear answer to the question. Patients with isolated local or regional recurrences of invasive breast cancer after mastectomy or breast-conserving surgery were operated. The local recurrence was removed. Then they were randomized to chemotherapy or no chemotherapy. In addition, they could have all types of other standard therapies like radiation therapy and hormonal therapy. Now, obviously, these patients are very heterogeneous because they had different prior treatments for the primary cancer. So this was a pragmatic trial where radiation, hormonal therapy, and anti-HER2 therapies were individualized. And the same is true for the chemotherapy. Of course, the patients on the no chemotherapy arm of the trial got no chemotherapy, but the investigators were free to choose appropriate chemotherapy for the patients on the chemo arm based on prior therapies. We recommended that they use 2 drugs at least and that they treat 3 to 6 months. Here are the results. Please focus on the left panel. This is disease-free survival. With a median follow-up of 5 years, the chemotherapy group has a disease-free survival of 69% and the no chemotherapy group of 57%. The absolute difference of 12% at 5 years corresponds to a hazard ratio of 0.59. This is a relative risk reduction of 41%, and this is statistically significant with a p-value of 0.045. On the right side, you have the overall survival with a 5-year survival probability of 88% for the chemotherapy group and 76% for the no chemotherapy group. Again, a 12% absolute difference. This corresponds to a hazard ratio of 0.41 or a 59% reduction in risk of death. The benefit was larger for patients with estrogen receptor negative recurrences. The data is not really mature for patients with estrogen receptor positive recurrences. So the conclusions are as follows. We think that adjuvant chemotherapy should be recommended for patients with completely resected, isolated, local, regional recurrences of breast cancer. The argument is strongest for patients with ER-negative recurrences, and we need longer observation for patients with ER-positive recurrences. Thank you.